Ulcerative colitis, as you all know, is a chronic inflammatory condition causing continuous mucosal inflammation of the colon. It was first described by Samuel Wilkes in 1859, and since then so much has been said about this disease. He first described this as an idiopathic ulcerative colitis, which was different from infective colitis. And since then, we have come to know about the etiopathogenesis, the etiology, and the treatment of this disease. Now, if you look at the prevalence, that we see that it is very common in North America, Europe. We do see some cases in Asia also. And regarding India, there has been a study which showed that there was a prevalence of 42.8% in one of the studies. And in another study, the prevalence was 44.3% and an incidence of 6.2%. So that means this disease does exist in India, and we do see it in Valley. But to tell you very honestly, we do not have the prevalence and the incidence of this dreaded disease in our valley. But we do see cases. As I earlier said, it is a multifactorial disease. It has a genetic component, it is autoimmune. So many incriminating factors have been incriminated in causing this disease. Genetics, we know from Ashkenazi Jews, they have a very high incidence of ulcerative colitis than their non-Ashkenazi Jews. They have a 3 times more higher propensity of having ulcerative colitis. So that gives a clue towards the genetics of this disease. If we look at a patient of ulcerative colitis, 10 to 20% of patients have a family history. So that's one more clue towards the genetics. And we all know that it is an autoimmune disease. I would not go into details because that would take a lot of time. So many things have been included, from diet, infection, the non-steroidal anti-inflammatory intake, oral contraceptives. The diet has been included because they believe that if you take a high carbohydrate diet or a high fat diet, and people also believe that appendectomy has also some influence of ulcerative colitis, and smoking and other things. Now, if I just try to hypothesize what are the etiological hypotheses, they believe that there is a persistent infection, especially in our population, which may be in form of mycobacteria, listeria, and there may be a defective mucosal integrity. That's altered mucus, increased permeability, cellular starvation, and impaired restitution. And basically at the heart of it is a dysbiosis. That is, there's a decrease in protective bacteria, and there's an increase in aggressive commensals. And there is a dysregulated immune response. There's a loss of tolerance, there is an aggressive cellular activation, and there is a defective apoptosis. And this is again showing the genetic susceptibility of patients, though it is more in Crohn's than in ulcerative colitis. This is the difference between monozygotic and dizygotic twins. That's what points towards the genetic etiology of this disease. Now, this is a small overview. I do not go into details. Basically, what happens whenever there is an inflammation or there is an antigen, there is controlled expansion and there is no inflammation. But in inflammatory bowel disease, what happens? There is an uncontrolled expansion of the inflammatory cells. There is a disparity. There is a defective apoptosis and inadequate suppression, so that there is more of inflammation. So this is again the same, that there are multitude of factors, from traumatic causes to environmental causes and the genes. This is again the same. But finally, what is the net result? The net result is that there is an ineffective immune response. There is a programmed over-responsiveness to inflammation. And that's what we believe to be at the heart of the etiopathogenesis of ulcerative colitis. So again, multifactorial causes, the luminal microbial entry, the immune response, the genetic susceptibility, they all come together and finally lead to the inflammatory bowel disease. And diagnosis, you all know, can be from the history, from the laboratory workup, and endoscopy. And the clinical picture is not unknown to you. The same presentation of bloody diarrhea, abdominal fever, and some patients may have even constipation. 20 to 30% patients of ulcerative colitis may present as constipation. And what is the heart of this disease is that you have an extra-intestinal manifestation. So it is not limited to intestines. You have a dermatological, ocular, musculoskeletal, and hepatic. So that is another clue that it is an autoimmune disorder involving multiple organs other than heart, other than the colon. So dermatological, you all very well know that there's erythema nodosum, there's a rash, which is a raised erythema and papules. The skin signs, again, these start as erythematous plaques, papules or blebs in the peritibial region. They can progress to ulcerated, necrosing tender wounds with ill-defined purple-red marks. This is one of the photos showing the pyoderma gangrenosum. You can have ocular signs, you can have episclerites, irites, and uveitis with all the protein manifestations. And these ocular signs they always have that, they show that activity of the disease. Eye manifestations, these are the pictures showing episclerites and uveitis. You have a musculoskeletal, you can have a pauci-articular, you can have a polyarticular involvement, and what's very interesting is that they have ankylosing spondylitis. 3 to 5% of patients are at a risk of having this, and they have an antigen which is HLA-B27 in these patients. They have a loss of truncal motions, chest expansion is decreased, they have a tender sacroiliitis, even the liver is not spared. You have fatty liver, you have a cirrhosis, you have a sclerosing cholangitis, and you have an autoimmune hepatitis. And what happens if you have an increased risk of cholangiocarcinoma? So if you see patients who have an ulcerative colitis, they have a 30% higher risk of developing cholangiocarcinoma. Then the other markers are the serological markers, the PNCA, the ESCA, you all know. And we measure the disease severity clinically. We have a mild disease, as severe, and sometimes patient may directly present as a toxic megacolon. So this is one of the pictures showing a toxic megacolon. This is one of the presentations sometimes of an ulcerative colitis. These are the colonoscopic pictures. I will not go much into details. You see a continuous disease, you see ulceration, and you can grade them accordingly. And what's important, that 18 biopsies should be taken within, with 4 biopsies from the rectum. So please remember, when you're making a diagnosis of ulcerative colitis, take 18 biopsies. And histopathology, you all know that though it is not something classical, but you have a distortion of colonic architecture with loss of crypts. You have a cryptitis, you have a crypt branching, you have a crypt abscesses. And you can see how dreaded this disease is and how difficult is it to treat. This is one of the surgical specimen. What happens to colon? It becomes thick. It is all full of these polyps, which are normally called as pseudopolyps. Now, what are the therapeutic goals in inflammatory bowel disease? We should have a clinical improvement. We should have a clinical remission, because as I earlier said, it's a disease characterized by exacerbation and remissions. Corticosteroid meaning there is a maintenance of remission and maintain tissue of healing, because corticosteroids, you know how much complications they have in a patient. You should have decrease in hospitalization and surgical interventions. You should prevent complications, and you should change the natural course of the disease. Now you know that you can see the extent of the disease. If you have only proctites, you can have a left-sided colitis, and you can have an extensive colitis. Now what are the criteria we use? We use criteria like symptom remission. What does it mean? When you have a normal stool frequency less than 3 days with no blood in the stool. You have an endoscopic healing. You have a normal glucosa. And what is a complete remission? Both symptomatic remission and endoscopic healing is called as complete remission. Because these terms are very important when we go to the treatment of this disease, medical treatment. Now you all know that we have to first induce a remission. And in mild disease, we have the molecules 5-ASA, which may be used topically or orally, or you can use in a combination. In moderate disease, you add glucosteroids, you add azathioprine or 6 mercaptan disease-modifying drugs, infliximab, and alpha anti-tumor necrosis factor like infliximab and adrenaline. And if you have very severe disease, you may have to give IV corticosteroids, cyclosporine, infliximab, or vedolizumab. Now, another I said is that we have to maintain the remission. The maintenance therapy is again 5 amino salicylic acids, azathioprine, and infliximab. Now, what are the definitions of treatment failure? When do we define that medically we have failed to treat this patient? 5-SA failure, inability of the patient to achieve and maintain complete corticosteroid-free remission, despite optimal treatment with oral, rectal, or combination of 5-SA therapy. Or we have a thiopurine failure, inability of patient to maintain corticosteroid-free complete remission despite dose optimization, meaning the maximum dose of corticosteroid up to 60 milligrams. Now, what are failures? You have a primary failure, you have a secondary failure. The primary failure is inability of a patient to achieve corticosteroid-free complete remission despite dose optimization. Secondary failure, inability of patient to maintain corticosteroid-free complete remission after achieve a symptomatic response. Now, these are the recent Toronto guidelines for treatment of left-sided extension from mild to moderate. So you start with rectal 5-ASA, which is about 1 gram per day, or you use oral 5-ASA 2 to 4.8 grams per day, and for extensive you use oral and rectal ASA molecules. And then what do? You assess these patients after 4 to 2 weeks and look for symptomatic reform. If yes, we have to continue oral or rectal 5-ASA. If there is no response, we have to optimize dose with the maximum dose up to 4.8 grams and assess for complete remission. There's a marker that this complete remission, some people, there is no consensus on it, but some people is about 4 to 12 months. And if after this there's again no response, what is it then? Then what do? You add oral corticosteroids, assess 2 weeks for symptomatic response. If the response occurs, then you start oral 5-ASA, or you start thiopurine or monotherapy, or you start anti-tumor necrosis factor with or without thiopurine or methotrexate, or you start vedolizumab and thiopurine or methotrexate. Then again assess them for after 8 to 14 weeks for symptomatic relief. If there is a relief, you continue the therapy, or if there is no relief, you optimize ASA therapy or consider switching therapy. You have to major thiopurine metabolites or consider switching therapy. So you switch to anti-tumor necrosis factor, or you consider switch to another therapy or to vedolizumab, or you continue to switch to an anti-tumor necrosis factor therapy and assess for complete remission, which is again from 4 to 12 weeks. Now, what are the consensus guidelines for corticosteroid resistant dependency? So what do? You add vedolizumab or thiopurine or methotrexate, or you add an anti-tumor necrosis factor plus thiopurine or methotrexate, and assess them at 8 to 14 weeks for symptomatic response. If there is a response, continue these drugs, and you have to assess for complete remission again at 4 to 12 weeks. Follow up for loss of response. If there is loss of response, you switch to anti-tumor necrosis factor. And in patients, you assess after 8 to 14 weeks for symptomatic response. If there is no response, you add anti-tumor necrosis factor, thiopurine or methotrexate. Now, if you continue anti-tumor necrosis factor or thiopurine, you can assess again for complete remission, follow for response. If there's a response, we can continue the drugs. Now, we have to have biological agents in inflammatory bowel disease. Actually, there is an inflammation, and you have a pro-inflammatory factors and anti-inflammatory factors. In a normal person, these are balanced. But what happens in the patients who have an inflammatory bowel disease, there is an imbalance. So what happens? The anti-inflammatory take over and lead to this disorder. Now we have now newer drugs, which I said initially. They are infliximab, adalimumab, and golimumab. They are alpha tumor necrosis factor. So these are the trials. With these, you have an ACE1, ACE2, what are called as Ultra-1 and Ultra-2 trials, and they have shown that there is a significant improvement with infliximab and adalimumab in patients who are either failure of the treatment of 5-ASA or who are treatment naive. Now, what are the contraindications of tumor necrosis factor? If you have an active abscess, if you have a suspected acute tuberculosis, intestinal obstruction, multiple sclerosis, congestive heart failure, or a previous lymphoma. Now, what are the limitations of these currently available options. I said 5-ASA is the cornerstone of the treatment, but you have a hematological abnormalities, you have hypersensitive reactions, and with corticosteroids, you all know when we give corticosteroids to patients, how they suffer. They have adrenal suppression, susceptible to infection, weight gain, and osteoporosis. Methotrexate, you know, it causes dyspepsia, alopecia, myelosuppression, abdominal pain, headache, and arthritis. Same happens with alpha tumor necrosis factor. I said what are the contraindications to these drugs. Now there are newer target therapies. What are these target therapies? Basically, I said that at the heart is the inflammation. What happens? There is a migration of these inflammatory cells, and there are drugs which affect them. That is vedolizumab, natalizumab, and others which have come into the market. Now it is like treating ulcerative colitis like dealing with the shark. You know, it is not a mammal you can curdle like it is shown here. So now the drugs which have come is vedolizumab. Its mechanism of action is that it's a human monoclonal antibody that binds exclusively to alpha-4 B7 integrin and blocks the interaction of alpha-4 B7 and which finally causes localized blood vessels with intestinal mucosa and gust into the lymph tissue. So the mechanism of action of vedolizumab works to reduce inflammation in the gut. So what I said is a disimbalance between inflammatory and pro-inflammatory agents which finally lead to this inflammatory bowel disease, wherever ulceration, and you have an involvement of other organs in the body. So these are the Gemini trials which have been conducted and have shown that with vedolizumab you can have a good primary outcome and a secondary outcome. You can achieve a remission with these drugs. I'm not going to details, I'll just pass on that. So, and this drug has been recently approved for treatment of ulcerative colitis. And it is very good drug for those who do not respond to conventional treatments such as steroids, immunosuppressive agents, or tumor necrosis factor. This is another this drug, vedolizumab, which has been used again, and these are some of the trials which you will see that they show a better clinical response to patients who are resistant to the treatment or who are treatment naive. So finally, the interpretation of these is that vedolizumab was more likely to lead to clinical remission at week 10 as was placebo. Therefore, blockade of both alpha-4 beta-7 and alpha-E beta-7 might provide a unique therapeutic approach for treatment of ulcerative colitis, and phase 3 studies are already being planned. Now there are other which you can use is JAK inhibitors, what are called as JAK inhibitors like tyrosine kinase, and the important drugs which is available is tofacitinib, which is available and has been used in moderate to severe ulcerative colitis, and it has shown good results as compared to the placebo. And now another which has been used in ulcerative colitis is fecal microbial transplantation. That means you transplant feces of a normal patient who has been already screened for hepatitis B, C, E, and for other systemic disease to a patient who has an ulcerative colitis. So these are the trials. Recently, which was in NEGM, this trial came that the measures of outcome of patients who had a microbial transplantation compared with placebo. And the conclusion was that this fecal microbial transplant induces remission in a significantly greater percent of patients with active ulcerative colitis than placebo, with no difference in adverse events. Now, other methods have been used like leukocytopheresis, which removes 65% of neutrophils, 50% of monocytes, 2% of lymphocytes. But it has been seen that session lasts for an hour, during which time 2 to 3 liters of blood is drawn from one arm, filtered and infused around. It's very costly. It's not yet available. There are some only trials, and it has been yet available in Japan only. It's very expensive, and we have yet to have controlled trials. Now, one more wonder drug has been seen, that is curcumin. And what's curcumin? I think you all know, is haldi basically. It's a biologically active phytochemical compound obtained from rhizomes of curcuma, and it has been tried in ulcerative colitis. Now, if you see that in Indian medicine, it is being used for a lot of disease in India, but now it has been found to be anti-inflammatory, and people have tried it in ulcerative colitis. Basically, as I earlier said, this ulcerative colitis is nothing but an imbalance between pro-inflammatory and inflammatory cells. There are these KKB kinase cell. There leads to activation of nuclear factor kappa light chain B cells, which cause nucleus to translocation and finally release of pro-inflammatory cells. And curcumin is believed to prevent this NFKB, prevent translocation of the nucleus, and prevent release of inflammatory mediators, which finally lead to inflammation. And there are some of the trials which have shown that there's a clinical improvement if you add to mesalamine in moderate ulcerative colitis. This is the trials, the results of those trials, and they have shown that even relapses are very less if you add curcumin to mesalamine or AZA molecules. Now, despite all this, we still need surgery in this patient. You have indications where there's a colonic dysplasia, there's a carcinoma, there's a perforation, there's a growth retardation, intolerable or unacceptable side effects of medical therapy, medically refractory disease, systemic complications that are recurrent or unmanageable, toxic megacolon, which does not respond to medical management, uncontrollable colonic hemorrhage. And finally, again, the road ahead is very tough. And now the newer strategies which have been developed, as I said, have been developed according to the etiopathogenesis of the disease. That means mainly restrict against inflammation, their molecular blockade, which may finally lead to the control of the disease. Now, what are the facts? Despite all this, some facts remain. Risk of cancer is low during first 8 to 10 years, then increase in a rate of 1 to 2 years. Malignancy may be present in 18% of patients after 30 years of the disease. Relative risk, that is 2.6 to 5.4 fold is the risk as compared to the general population. And first colonoscopy after 10 years with invariably revealed dysplasia. So what are the conclusions? The introduction of biologics has changed the treatment, as I showed you from the trials, treatment paradigm for moderate to severe ulcerative colitis. With the use of anti-tumor necrosis factor, mucosal healing is now regarded as the treatment goal. In future, we believe that biological agents with superior therapeutic effects and fewer side effects compared to those used currently will be developed, thus bridging the therapeutic gap present in the treatment of ulcerative colitis. Thank you.